Thank you very much, Nick. It's obviously a topic of some importance. Septic acute kidney injury is the most common form of acute kidney injury in developed countries, particularly in intensive care units. We have quite a lot of data to show us that's about 50% of all the cases that we see. Other than if acute kidney injury develops that is severe, there's no specific therapy, and we have not advanced our ability to deliver specific therapy because we've got a limited understanding of its pathogenesis. So today I will talk about some of the hemodynamic aspects of septic acute kidney injury and what we believe we can understand about it. In order to study the hemodynamics of acute kidney injury in an invasive, highly sophisticated way, you cannot do studies in humans, and you have to create models of sepsis. And we spent quite a lot of time over the last 20 years trying to develop a model of gram-negative bacteremia in a large animal that would enable us to measure all sorts of aspects of hemodynamics. This is a representation of how the model works. We induce a septic model by administering intravenous E. coli to sheep, and you can see sheep are all instrumented chronically, so they were able to continuously measure every heartbeat, both the mean arterial pressure, the heart rate, the cardiac output, and as I will show you later, the renal blood flow through a transit time flow program, the renal artery. And you can see that if you inject gram-negative bacteria, you develop tachycardia, a cardiac output increases, and the blood pressure over a period of time decreases. And you can see at the end on the right side, the study period when we're focusing on looking at what's happening to renal blood flow and renal hemodynamics in the setting of what is hyperdynamic sepsis. Well, the first observation that we've made over the years is that persistently and consistently, when we measure renal blood flow in hyperdynamic sepsis, there is a significant degree of vasodilatation of the renal vasculature. So, renal state with increased renal blood flow, which is related to vasodilatation and is not easily or corrected properly by noradrenaline administration at relatively high doses. And this vasodilatation persists up to 24 hours after the administration of gram-negative bacteria. So that's the first observation. So when we create a gram-negative bacterial septic model, there is increased renal blood flow, there is decreased renal vascular resistance, but at the same time the animal develops oliguria and a significant reduction in GFR. So the initial insight from these experiments was that the traditional view that there is decreased renal blood flow is probably incorrect, at least in the early phases of acute kidney injury. So if there is increased renal blood flow, then we reasoned about how that might happen. And if you have a traditional view of the renal circulation, where the glomerulus is the final end point of that circulation, then for renal blood flow to go up and for renal vasodilatation to allow renal blood flow to go up, then there has to be both afferent and arteriolar vasodilatation. But if you have a similar degree of vasodilatation in that kind of model of the way the kidney vasculature might work, then you end up with no change in GFR. So logically, you might postulate that there would be a greater degree of vasodilatation of the efferent arteriole so that there is a decrease in pressure within the glomerulus. So it is possible that excessive, significant efferent arteriole is responsible, at least initially, for this hyperemic state and for the loss of GFR. Now, if that was true, one way to potentially alter that is to give a drug that is specific for the efferent arteriole, such as angiotensin II. as you know, in clinical practice, to inhibitors in order to induce efferent arterial vasodilatation. Here we want to do the opposite. So what would happen if you gave angiotensin II to septic sheep in the setting of gram-negative sepsis? What you do is you have an increase in blood pressure, as you can see there. You have limited changes in cardiac output, maybe increase in afterload, and you have a decrease in total peripheral conductance, which is the inverse of the resistance, consistent with vasoconstriction. As you would expect in this model, if you administer a continuous infusion of angiotensin, you will have a significant increase in renal blood flow. And of course, a decrease in renal conduction with renal vasoconstriction associated with efferent arteriolar vasoconstriction. But in this model, if you do that, if you decrease renal blood flow, what you actually get is a significant increase in urinary output. So you are showing that there's a dissociation between global renal blood flow and renal function if you vasoconstrict, so that the flow goes down, but the function goes up. And you can see that by measuring creatinine clearance as well, and you can see the same effect. So when you give efferent arteriolar vasoconstrictor in a model of gram-negative bacteremia, you have a significant improvement in function. Do we have any other evidence from vasoconstrictive agents that have a specific effect on the efferent arteriole that this might be potentially relevant to their use as well? We have evidence that arginine vasopressin has a greater effect on the lumen of efferent arterioles, and this ability may actually show up as an effect in function and renal blood flow in the same model. And so indeed, when you give arginine vasopressin, at least for the first 4 hours of treatment, there is a significant increase in urinary output, although not quite as large as with angiotensin II. So it looks like not only angiotensin II, but vasopressin, which are either very selective or partially selective efferent arteriolar vasoconstrictors, appear to help function by decreasing renal blood flow. Does this happen in human beings? Do we have evidence that there is vasodilatation in human beings? We really cannot measure renal blood flow easily in human beings. It's not possible to do that kind of invasive measurement. But using paraminopipurate in the 70s, there were reports in patients with intra-abdominal sepsis also showing that total renal plasma flow was significantly than normal. And in fact, if you go back to the 1940s, with work done in humans by Homer Smith, the father of American nephrology, and you measure renal blood flow with the technology available at the time, which is diaphragm clearance, you can demonstrate that after the administration of pyrogen, there is a significant increase in renal blood flow despite the loss of clearance. We also have indirect data in human beings. This is from the VAST study, a randomized controlled trial comparing noradrenaline to noradrenaline plus vasopressin, blood pressure support and acute kidney injury in patients with septic shock. And if you look at the changes in serum creatinine over time in the first 3 weeks after randomization in patients that had evidence of early renal dysfunction, those patients randomized to the addition of vasopressin appear to have better resolution than those randomized to noradrenaline alone. So we've got experimental studies showing that global blood flow is dissociated from function. Now, we have suggested in my first part of the talk that maybe efferent vasodilatation is responsible for this, but there may be other explanations. This is a picture of the way we understand with cast creation the renal circulation. Might traditionally see that as an afferent arteriole taking blood into the glomerulus and the blood coming out of the efferent arteriole. However, if you look at a variety of anatomical studies, life may be more complicated than that. And in fact, at least in rats and in mice, there's been demonstration that the circulation of the kidney is more complex, and you can have an afferent arteriole that runs past the glomerulus, feed into the glomerulus, but can also go straight past it as an afferent vein and bypass the glomerulus, providing an anatomical structure for shunting. This is data with 3D reconstruction of the outer portion of surface glomeruli from rats using 2-photon microscopy, and you can see very nicely a periglomerular circulation that would allow blood to come and bypass the glomerulus if changes in the circulation took place. And this has also been reported by other anatomists in the 70s. This is by Lundqvist from Sweden, creating a picture of what the glomerular circulation and the renal circulation look like, and kind of arguing through multiple anatomical preparations that blood could indeed go into the glomerulus, but can also follow a shunt pathway and go directly past the glomerulus. And if this is true, the circulation might be the place where the game of losing GFR, increasing renal blood flow, and having significant loss of function simultaneously may be played out. And we've gone to investigate the microcirculation. This is again our model of sepsis in the sheep. The plasma creatinine, you can see, rapidly goes up in 24 hours from 60 micromoles to about 120 micromoles. The creatinine clearance falls, the urinary output goes down, the fractional excretion of sodium goes down, but the global oxygen extraction goes down, suggesting that there is no significant oxygen debt or hypoxemia or tissue hypoxia taking place. When you look at the renal blood flow in this model, that goes up again as before, and the renal vascular conductance goes up, consistent with vasodilatation. But if you have laser Doppler flow probes, and you also have ability to measure tissue oxygen saturation at cortical and medullary level, you can see that the medullary tissue perfusion falls in a way that is different from the cortical perfusion, and whilst the cortical tissue oxygenation is maintained or increased, the medullary oxygenation falls quite significantly. So you can have global renal blood flow which is elevated, but that doesn't tell you what in the medulla compared to the cortex. And when you have this level of dissociation, then you find yourself not only having a dissociation between global renal blood flow on one side and function, but you also have a dissociation between global blood flow and flow to the cortex or the medulla. So it's really difficult to draw conclusions about what's happening to the kidney in sepsis, because even if you were able to measure renal blood flow in a global way, it's still what's happening at a microvascular level. With John Prowl, we looked at measurements of global renal blood flow by phase contrast MRI in human beings with sepsis to try and understand whether similar events might apply to human beings. And you can see that in a cohort of patients with sepsis, as the cardiac index goes up and you go into a hyperdynamic state, the renal blood flow goes up and the renal vascular resistance is altered. But you see in the slide below, there is a clear dissociation between the renal blood flow and the creatinine clearance. So that in human beings, like in septic sheep, knowing renal blood flow does not allow one to predict function. What about structure? What about the histopathology of the kidney? Is that also a source of surprises, if you wish? And we've looked at the histopathology of these animals that are in advanced acute renal failure after 48 hours of continuous infusion of bacteria, where there is a trebling of the serum creatinine. And when you do histopathological assessment and you compare the histopathology of these animals to those of normal animals, the pathologist cannot tell the difference. Is this also true in human beings? And the answer is yes. When you have rapid post-mortem studies, and this is the most recent paper, and you look at the characteristics of the histopathology of septic patients that have died of rapid post-mortem, the majority by light microscopy, suggesting that not only is function dissociated from global blood flow, but the structure is dissociated from blood flow and function, and the global blood flow is dissociated from cortical and medullary blood flow. So if you come to a conclusion from the experiments that we have done over the last decade, you have to that probably in human beings, as in experimental animals, there may be a high blood flow state, at least early on, with decreased vascular resistance. What drives the kind of vasodilatation is currently unknown, but it is likely that it includes shunting of blood away from the glomeruli with loss of function and, yes, increased blood flow at the same time, or maybe vasodilatation of the efferent arterial, or both. Or maybe other pathways that we still do not understand. And importantly, the dissociation may be because you might have lost pressure inside the glomerulus from efferent arteriolar vasodilatation, or because you're shunting blood away from the glomeruli. In the end, even if we knew about the macro circulation, which of course in human beings we currently cannot measure, it may well be the septic AKI disease is a disease of the microcirculation. If it is a disease of the microcirculation, can we manipulate it at all? And the answer is maybe. Maybe we can manipulate it. In human beings, what we've seen with angiotensin II in the sheep, and Dr. Chawla would know this very well, who's the principal investigator of a very exciting study, which is international and multi-center, of angiotensin II in septic shock, to see whether these experimental findings apply to human beings as well. Thank you very much.